So I have the opportunity to share or paint a picture for you of our healthcare and healthcare landscape. So often when we talk about healthcare, we're talking about medical care, but the landscape is much broader than that. In fact, when researchers have looked at contributors to length and quality of life, they estimate that access to quality healthcare contributes about 20%. The other 80% is comprised of health behaviors, about 30%, physical environment, about 10%, and socioeconomic factors, about 40%, or what we now call the social drivers of health. Oops, next. This is a picture of our beautiful Wrong Way River, the French Broad. In public health, we often talk about downstream, midstream, and upstream approaches to improving health. Downstream approaches focus on the individual and fixing a health problem, or the individual fix. This is medical treatment, ER visits, improving access to medical care, substance use disorder treatment. And of course, there's variation across these, right? Midstream approaches also focus on the individual or small groups, but tend to be more prevention focused. Health promotion, health coaching, social work, addressing social needs, and care coordination, even community health work. Upstream approaches focus on community level impact. This is where public health tends to step in, and policy for that matter. Infrastructure change to improve air quality, water safety, coordinated data portals, and systems such as our NC Care 360 and the, I always forget if it's IHE or HIE at the state level. I think it's HIE. Thank you. And then, of course, policy change to address health systems and workforce, wages, equity, educational opportunities, and so forth. We do need to fix access to and utilization of primary care and other types of care in rural areas. There's no doubt about that. And it's also important to value all the other people in the workforce, health workforce, who are dedicated to supporting healthy behaviors, addressing social and economic needs, and supporting healthful physical environments. Despite our challenges, the Western North Carolina landscape is remarkably resilient. Two of our key regional assets are collaborative approaches and our focus on planning with results in mind. We do practical evaluation and drive our practice with evidence. Some great examples include the way we mobilized during the height of the pandemic with collaboration across organizations to communicate safe infection prevention practices and to promote equitable vaccine distribution. And leaders of some of those efforts are here. The North Carolina Center for Health and Wellness our work spans mostly midstream to upstream approaches, with our culture of results and health policy work as the most community level approaches, although the two projects that Jeff Bahar mentioned are also upstream projects. Our impacts are regional and in some cases statewide. So one of the things, I wanted to share a couple of examples of how these regional collaborations impact. One example is the collaboration between MAHEC and UNC Asheville with UNC Chapel Hill and the support of the state to bring public health workforce to the region. And to date, 94% of our graduates have stayed in Western North Carolina doing public health work. This is over 4 years. At the start of the pandemic, and as another example, we mobilized 90 student health ambassadors, and you met 2 of them a little bit ago, across 6 Western North Carolina colleges and universities. These peer educators help to keep campus COVID infection rates lower than surrounding communities and to keep students living and learning on campus throughout the pandemic. And for time reasons, I'm going to skip this last one, but my point is there's lots of collaborative efforts doing good works, making big impacts. And I'm just going to leave you with a couple of key takeaways. I think it's important to focus on the midstream and upstream strategies to support regional health impact. Let's include healthcare and keep going further on up the French Broad. which is easy since it goes the wrong way. And then continue to support collaborative, results-focused regional strategies for maximum reach and impact across the health and healthcare landscape. And now I hand it over to my colleague, Amy Russell.
Thank you.
Yeah,
Can everybody hear me? So there is not enough time to talk about ACOs, healthcare transformation, manage Medicaid. Just so you know, if you have questions, I have my card. Team members from MHP, if you'll stand up just so you know who they are. And then we have our last year's value report in the back if you have more questions. But I'm here to talk about the resource we have in Western North Carolina in terms of healthcare transformation. So Mission Health Partners was formed in response to transitions to value-based care. We have been in existence since around 2014. We became a Medicare Shared Savings Program in 2015. And we've been working to contract with a variety of different payers. You can see them all up here to the left. So we contract with all of the managed Medicaid standard plans. We now have a contract with VIA, yes. And we also contract with a lot of Medicare Advantage plans, and we have a Medicare Shared Savings Program contract. We also partner across the health system. So we have 3 health systems, Part E, Mission, and Murphy in our health system. And we have post-acute care facilities, home health, specialist practices, but the core of this is primary care, and we're really working with all of these practices together to transition. And you can see our footprint here in Western North Carolina. This shows you our name is Mission Health Partners, but we're much broader than Mission. So what do we do? How do we bring value to Western North Carolina? So we have a really, really unique model where we try to do upstream work, but we also do that as well as complex care management. So we have an infrastructure where we identify patients with high needs who are been in the hospital or in the emergency room a lot, or a provider refers them to us because they're concerned about it. And we have this multidisciplinary team that supports those patients. So we have physician leaders, nursing, social work, pharmacy, community paramedicine. We have community outreach specialists, which is like a community health worker, but they're trained to do a lot of things in the practice to see patients. And then we also have community respiratory care, and we have post-acute care coordination as well. And this group of people works collaboratively with our human service organizations in the region to try to meet individual needs. And with the transition to managed Medicaid, we use the platform NC Care 360 to make these referrals. So the great news about this is this model actually adds a lot of value to Western North Carolina. So just in 2002, when we've been doing healthy opportunities on the platform, we've done over 1,500 referrals for social needs. What that means is that someone on Laura's team, who's a nurse, who identifies a patient who's been in the emergency room. We had twins who were in the emergency room a lot with asthma. She says, I need a respiratory therapist and our community paramedicine. They go out to the home, they evaluate the environment. They say there are leaks in the roof, there's mold in the home, they live next to a farm, and they actually get resources in to help address these needs. And that happens because they go to Kelly's team, who has community outreach specialists, and they go and work with the family and connect them with these community resources. So that is a huge service. And then we see that actually those kids are doing better, and they're not in the emergency room all the time. We also see that our team, working with practices, we see improvement year over year in quality performance. That means improved preventative care screening, improved management of chronic diseases like diabetes, and actually payers pay us to do a better job. And we've had more than $17 million paid back to primary care practices for their investment in quality. We also have really high patient experience scores. So we used to be 5-star. Medicare's raising the bar because we're doing so well, and but we're typically higher than a 4.5 or a 5-star in patient experience. And we have more affordable care. So our total Medicare and Medicare Advantage savings shared is $32 million. That means that we've saved almost $60 million. The payers get the other half of that. $14.5 million in shared savings payment has been reinvested in our local primary care. That's really significant. The lowest Medicaid cost of care in Western North Carolina, I don't have data from all the Medicaid payers, but we do have data from United Healthcare on our cost of care, and we are the lowest in terms of cost of care for Medicaid in Western North Carolina. And we really believe this interdisciplinary approach with connecting with the community and community resources is the pathway to make that happen. So challenges and opportunities. We have a lot of market pressures. You can imagine if there's money to be saved, that there's a lot of people that want to participate in that, right? And not necessarily people who are as concerned about our local resources and reinvestment in Western North Carolina. There are changes culturally in our environment, and we're trying to adapt to that. So I think the questions we have are what policies are really important to our success in the future, and what we want to work on together is really understanding that investment in primary care, investment in human services, really has that downstream effect of the ability to reinvest in our communities and have our communities be financially successful. So care coordination, primary care, and policies that improve that integration. So we wouldn't be able to do what we are able to do without some technology and integrated health technology, and we've got a long way to go to make that better. So policies that improve that communication. I know we want to maintain competition in the healthcare environment, but that communication really serves patient. And then last, thinking about collaborative and team-based care models in a variety of different ways. So Dr. Sullivan and Dr. Bowie can only serve this region if we invest in that kind of support system, those collaborative care models that help rural practitioners keep a broad scope and serve high-risk patients in the region and provide the service. So again, that's what I have, and hopefully if you have more questions, just feel free to ask. Here are some resources if you want to read more about ACOs and accountable care and clinically integrated networks.
We'll share the slides with all of the attendees afterwards.
There we go. Good morning again. Again, I'm Erin Brash. I'm the Executive Director for WNC Health Network. We've been serving Western North Carolina for 26 years. We're a nonprofit organization that supports people and communities, people and organizations that contribute to healthy communities. So I was asked to speak about public health, and I really turned the tables to say, voila. This is the landscape of what it takes to have healthy communities across our region. So I'm going to talk more about the engine and fuel it takes to assure that what we're doing collectively is making a difference, and leave you with some resources that will be helpful in understanding, like, how are we doing in Western North Carolina with regard to the health and well-being of people, our neighbors. So Amy did a really good job of laying out this left-hand image, which is to say, it takes all of this for people to thrive and have long, healthy lives. Our policymakers are an essential part of the public health system, right? Policy making is vital to be able to make a difference in this right-hand column. That's what it takes for people to be healthy and thriving. And then I want to point out on the right-hand side, this describes the foundational public health services. And when I say engine and fuel, to make sure like we have what we need to make sure we're collectively making a difference, I'm talking about these services up above. So the ones that are circled, our agency has a very specific role in Western North Carolina in supporting both our local public health agencies, our hospital partners, community-based organizations, in doing assessment and surveillance, developing community partnerships, high-quality health communications, and then establishing performance systems to be accountable for what we're doing, and is what we're doing making a difference for folks. A shout out to my local public health partners. Karen is here representing Region 2, because that core work on the bottom side is really the heart of what we depend upon for like the essence of public health in Western North Carolina. So for the last 11 plus years, we've had the privilege to bring together local public health, hospital partners, regional partners, to collaboratively address some of those core needs. So we started out looking at how do we do surveillance in Western North Carolina? Do we have the data we need? And 11 years ago, the answer was no. We want more local, regional, more timely data. And so together with financial support from the hospitals in our region, do a triennial survey on the health and social conditions for people in Western North Carolina. That is a data source unique to Western North Carolina, unique in the state. And you can access those data and that data set on our website, and I've shared a link with you. This image on the left reflects what we know we do with data, right, as we make decisions with it. And so we also support local public health and their partners locally to make sense of that surveillance data, to make priorities, to establish priorities for their community, and then take action and be accountable for the results of those actions. I'll share something else related in a moment. So on our website, up on the right-hand side, you can see where I've circled a couple of ways to get to that data resource. And on the right here, you can't read what's in there, but there are about 10 to 12 key health issues that have risen to the top. It's like this really stands out in our region. And there are narrative stories of how are we doing in Western North Carolina on the number data? How does that compare to state and national? What's the story behind that? What are our partners, what are key leaders, health leaders in local communities saying is helping, is getting in the way? And then if you scroll all the way to the bottom, you can see a list of here are things that are happening to address this. So it's a great resource to say, hey, I've got someone talking to me about diabetes or about maternal child issues. Like who are some of the people I can reach out to that are content experts? This is a great first place to start. And then down here, when you request our regional data, you fill out this form, it'll go away, and you download a spreadsheet. Not only is that survey data in there, but we also curate all the various data sources. So instead of going to 100 places or having your staff go to 100 different places to find relevant data that is at least county specific for Western North Carolina lives in this spreadsheet that y'all can access and use. We know from a very small sample of the more than 250 folks who downloaded and used this data last year that we've leveraged more than 6 million, people have used this to leverage more than $6 million in grants into Western North Carolina. So we are happy to share this resource with y'all. And then I'll also point out one more page on our website. So I mentioned the support for local making sense of data and establishing community health priorities. So this is here are the big issues that we're really concerned about, and local partners work together to establish those issues. So here you can float over and those little dots will reveal what the health priorities are in those counties. And then further down on this page, you can link to the community health assessment, which gives a lot more detail about those priorities and how they were established, information about those priorities, and contact information for the folks who are pulling those reports together that could link you to other partners in those communities. So those first two bullets are the links to the resources that I just shared. The third bullet, I want to end by talking about, again, the heart of public health in Western North Carolina being our local governmental public health agencies. Public health is private, public, all of that. But there's been a huge strain on our local public health infrastructure over the last 3 years. And there is a deep conversation locally, regionally, statewide, nationally about the local public health infrastructure. And in North Carolina, just a couple of weeks ago, the North Carolina Institute of Medicine put out a report on investing in the future of local public health in North Carolina. They were able to UPS me a small stack. I don't have enough for everybody, but I do have a stack up here. And really public health experts from around the state, including a health director from Western North Carolina, some folks on my team, probably some folks here in this room, were part of that conversation and have some recommendations of what the needs are for public health in the state, and specifically we could talk about our region. Thank you. Oh, sorry. If y'all know me, I could talk forever, right? So I made myself stick to this, but then the writing got really, really small at the bottom, and I forgot the smallest writing. So my takeaway is our organization can either support you or connect you to people who can support you in the areas of collaborating across agencies, health communications. We've got some innovative collaborative health communications happening in Western North Carolina that I'd love to tell you more about, so see me later. Population health data, and then in listening to people. One of our core values is that we don't just show up and do work in communities or show up and do work in the region to say this is what we think needs to happen, but we listen really deeply. So, for example, in our communication work, we've been listening to people with lived experience with substance use disorder, who are in active use, who are in recovery, to form the foundation of some of the projects that we work on. So we would love to connect you to some of that information as well. Thank you.
Great. So we have